All right. Welcome to all of you who have been attending our 2025 CPD series or new attendees today. In this series, we wanted to take the opportunity to revisit core concepts in O&P education and share how we're approaching these topics here at Baylor College of Medicine. We sent out a survey prior to this year to gauge where our biggest perceived academic practice gaps were, and we've used that survey to tailor these presentations. We really want these sessions to be interactive, so we hope that you'll share your thoughts on how clinical practice differs from or aligns with what we're sharing from the classroom. A little bit of housekeeping. You all should have received the link to the post-session survey in the folder where the eventual recording of the session will be housed. Make sure that you take the survey within 30 days. You can take it after that, but we won't be able to give you credit through ABC. And then as a reminder, if you're not able to attend a session live in the future, you can hop back into that folder and watch the recording. Just make sure again that you're completing the quiz and evaluation within 30 days. A little bit of a note, and I have this in the slides as well. Our institution will no longer be using Zoom as of July. So we will need to send out a Teams link for our CPD sessions starting in July. So just a heads up, trying to prevent as much confusion as possible. All right, with that, I'm happy to introduce our speakers for today. You all likely know me. I'm Ashley Mullen. I'm the program director for the O&P program here at Baylor. I'm going to be sharing some information today about the content that's currently taught within our clinical practice management courses and some of the ways that we address professionalism with students and residents. And joining me today is Lisa Abernethy. She is our Associate Director of Clinical Education and Assistant Professor in the program. She directs the Transition to Practice coursework, some clinical seminar coursework in health behavioral counseling, and as clinical coordinator, she's uniquely suited to present information about bridging the first year of the program with the residency portion of the program. So with that, I will start sharing. All right, just to make sure, Lisa, you see the slide? Awesome. Okay, so we're going to go ahead and get started. Actually, I jumped a few slides ahead. Here we go. So our course objectives today are to describe current topics in certain areas of our master's curriculum and hopefully have a great discussion about where things align or don't with clinical practice. Typical disclaimer for these courses, strictly due to the nature of time, we're not able to share everything that we teach in these courses, but we've pulled out some highlights for discussion today. Today, we'll be talking about coursework in clinical practice management, some academic and professional progress meetings, transition to practice coursework, and health behavioral counseling. All right, so starting with our CPM course. So here are the KHEP standards, which are associated with the clinical practice management course. As you guys are looking at these standards here, I hope this helps give you a framework in terms of what we mean when we say practice management. I think this term has a variety of interpretations across the profession in terms of what that means. Does it mean running a clinic? Does it mean understanding how to code? Does it mean having a solid foundation in healthcare economics? So hopefully you'll have a little bit better understanding of what we mean by that when we go over some of the curriculum. So in this course, our course directors have previously referenced these materials, but most of the readings have been provided to the students as excerpts of either published documents or textbook chapters to help inform them. From the pre-CPD session survey, we identified some areas for discussion today, and those are SOAP notes, coding, and LCDs or local coverage determinations, insurance requirements and reimbursement, and workflows and WIPs, work in practice. So for the SOAP note, we actually teach the SOAP note by hand here at Baylor. We've had a lot of discussion around using EMR systems or having the students learn this process only with EMR systems. And one of the things that we found is that the residents encounter usually at least 3 different EMR systems in their residency rotations. And they're able to pretty quickly get up to speed in utilizing those platforms. So we felt like here in the first year in the program, it was very important to give them a solid foundation in how to generate a SOAP note independent of any EMR system. So we teach the conventional SOAP note where the subjective is patient reported, even if it's clinician directed information. If it's patient reported, it goes into that section. The objective portion of the SOAP note is anything that was clinician observed or measured. The assessment portion of the SOAP note, and this is a distinct section compared to what this looks like for a physician's note, right? Where here a physician might be coming up with a diagnosis or a list of differential diagnoses. In orthotics and prosthetics, this is where we teach the student that their clinical assessment of the subjective and objective portion should lead to a prosthetic and orthotic treatment intervention or recommendation. So here's where we teach the students to reconcile objective and subjective portions of the note, include their full recommendation with indications and justifications. And then in the plan portion of the note, we teach them to include here what happened either at the visit, what will happen to implement the treatment plan, and how this plan might be supported by the assessment mentioned above. This is also the location where we ask the students to include next steps, reiteration of goal articulation that might have already been documented within the subjective portion of the note, and any patient education that they provided. Our students generate SOAP notes for a variety of encounters with our patient models ahead of the residency. So we do have them practice writing these SOAP notes in different clinical contexts, predominantly starting with the patient evaluation, including casting and then plan for the fitting procedures following. But we also have them generate SOAP notes for those fitting and kind of imitation follow-up type appointments, just trying to get them used to that task and shifting the framework of the SOAP note depending on the type of clinical encounter. For coding and LCDs, this is a portion of the program that I think from the beginning of the program, it's been really important to us that we included some aspect of coding and the business of O&P. This has changed a bit over the years and really tried to dial down towards what's going to be useful for the residents and future clinicians on a daily basis. And again, focusing really on that resident and early career clinician rather than the business owner at this point in the program. So for coding, we provide an introduction generally to the billing and reimbursement system. This is something that most of our students coming in, unless they have kind of managed their own healthcare crisis through the third-party payer system, they have limited awareness of what this means. So we start with basic terminology, like the language of insurance. What is a deductible? What is an out-of-pocket max? What is a premium, and how does that differ from a deductible? How do I calculate coinsurance, and how does coinsurance differ from a copay? So we're introducing the students to all of these things so that they can go out into clinic and kind of apply that understanding. The clinical practice management course also covers LCDs or local coverage determinations. And this course has been able to align that with their O&P courses. So when the students are in pedorthics with Lisa, they'll be going over the therapeutic shoe bill and LCDs in relation to diabetic shoes and inserts. When they're in lower limb orthotics 1 and lower limb prosthetics 1, they'll be reviewing and applying the LCDs associated with that course content. And then, of course, they have assignments where they generate these SOAP notes with their encounters and with the patient models. And then their SOAP notes are reviewed in accordance with those local coverage criteria. So did they articulate the things that Medicare and most third-party payers are looking for in association with coverage of orthotic or prosthetic intervention? Some foundational concepts for billing that this course covers as well are differentiation between Medicare Part A and Medicare Part B, and what that means for orthotic and prosthetic coverage at certain points in the continuum of care. The course goes over the 48-hour rule and the provision of advanced beneficiary notices. When are those things appropriate? And we even bring up some instances where all of us as faculty have kind of maybe seen these applied in a way that wasn't quite true to the intent of the regulations. And so helping them to navigate those conversations. And then all of this, right, is within the context of understanding the differentiation between important documentation that O&P clinics rely on for billing. So that standard order, a detailed order, a proof of delivery. What do those look like? And ensuring that the students are aware that those are needed to process billing. So just as an example, one of the class activities is to look at an explanation of benefits, to go through and pull out terminology on that EOB so that the students have some introduction to those terms and applying those basic terminology that they learned. They're also exposed to the fee schedule, so they know where to go find the Medicare fee schedule, particular to a state, and look up those HCPCS codes and that allowable fee. In the first year of the program, we kind of introduced them to the idea of the cost of goods and how that might come into consideration and should come into consideration when they're out in clinical care. There's a bit more exposure to that once they're out in the residency portion of the program, and they're really kind of living that day to day. In terms of letters of medical necessity, again, there's an introduction within our first clinical practice management course to the concept of a letter of medical necessity, and the various levels of evidence that may be supportive of a letter of medical necessity. And then in our Clinical Practice Management 2 course, which currently occurs during the residency portion of the program, it's going to be moved back into the first year, but we will continue to have an aspect of practice management that we do teach during the residency, because there's so much important context that really hits home once the students are out in residency. So on that note, wanted to share with you guys what kind of happens in that secondary course during residency, what's revisited and what's new. So these are the learning objectives from that Clinical Practice Management 2 course. This is our current clinical seminar 4 of the 5 clinical seminars. So in that course, the residents revisit Medicare, Medicaid coding and billing policy, revisit local coverage determinations. Now they've been in practice, they've been writing notes. What are they seeing? What are they doing on a consistent basis? And in addition to that, this is really where we get into having the residents describe the revenue and expense cycle of an O&P practice. We've really found that they just don't have the context to do that within the first year of the program. But now when they're out in residency, they're seeing this, they're part of these conversations. They're really able to lean into this part of the equation and often have a lot of really, really important questions to ask and topics to discuss. So you can see there that second new bullet point, discuss contemporary issues in clinical practice management. We expand this here for the residents. So they discuss patient advocacy, clinical engagement with the community, and professional development as a clinician. And then the final assignment in this course is for the students to work in small groups to outline a clinical workflow and discuss the implications of that workflow on clinical practice models. So again, here, we're really trying to leverage the residency experience so that they can start to weigh the pros and cons of, practice size, practice location, type of clinical practice. Are we in a not-for-profit institution? Are we a for-profit institution? And use that to inform their group's recommendation for best practices in clinical flow and clinical practice. All right, so this was a very, very brief high-level overview of some of the foundational content that we hit on in the clinical practice management course. One additional piece, because this session is related to professionalism as well, I wanted to share with you guys is for a long time in the program, we've had a longitudinal approach to kind of teaching and engaging with the students on professionalism. We've had early in the program, we had faculty mentor meetings. Those turned into what were called ongoing support meetings. And now they're called academic and professional progress meetings. We meet with the students and residents every quarter. And we go through a self-assessment that the students and residents do in relation to professionalism. This is only a portion of that form. There are other questions on that form in relation to academic progress as well. We also meet with the preceptors now. Each faculty member follows a resident through the residency portion of the program and then meets with each of their preceptors. And one of the questions we ask is, do you have any concerns about professionalism? Is there anything that you'd like us to be aware of? So here are some of the things that we really try and teach the students to engage in the first year of the program in support of them in residency, as well as just fostering professional everyday activities that are going to be beneficial to them once they're out in clinic. All right, so a few questions before I hand things over to Lisa. So we have some prompts here for you guys to consider, but if you're like burning to share something that has nothing to do with this prompt, I encourage you. So our first prompt, what do you wish new residents could do on day one of residency regarding practice management and professionalism? And I think that question is really getting at, do you see a mismatch, between where they are when they start residency and where you'd like them to be? And the other question or reframing of that would be, what type of guidance do you provide to residents or new clinicians regarding these topics? So we'd love to hear from you guys. And you can put something in the chat if that's easier for you, given your situation right now attending. I will just share a little bit of our own internal answering of this question and then program changes over time. We survey our alumni on a fairly regular basis. And we did a much broader survey about 18 months ago. And one of the things that we saw fairly consistently in some of that feedback was really wanting additional support and curriculum on coding and billing practices, really starting to get into the details of that and feeling like they needed a little more structure to that beyond what they were experiencing in the residency rotations. So we've made some adjustments to the coursework to try and facilitate that, but I think there's room to grow. So thank you, Connie. So there's a note in the chat, and I think this relates to professionalism. Facilitating residents or encouraging, you want residents, I think this is the answer, to be able to have small talk with patients to break the ice. Yeah, I think ideally that's the case. I think we all know that, especially early on, they're very focused on executing a task and making sure that they're executing that task properly. Well, we'd love for them to be able to do that with a little bit of small talk. We know that that will take some time and comfort. But we do try to practice that.
Ashley, this is Eric. Kind of along with what Connie said. So I generally start my residents out, obviously, with a bit of shadowing, but very quickly I like to start sending them in the room by themselves to meet the patient, to initiate that, and then to take the history. Like that's where I start them. Like take a full and thorough history, come on back out, present that to me, then we kind of go back into the room together and so that's where I kind of start them out and then progress, through more independence in the appointment from there.
Yeah, Eric, thank you so much for sharing. I think that's a really important point, and we share that approach with the students as well ahead of residency as just what you described, right? Like taking a patient history is like a incredibly low stakes approach to getting an idea, the preceptor getting an idea of where a resident is at. So yeah, that's a great example. And then the resident being able to present their findings as well gives the preceptor some information on how they're connecting the dots. All right. Well, keep thinking. We may have some time for more questions at the end, but I'm actually gonna um, pass. We're gonna stop. I'm gonna stop sharing and let Lisa share her slides. Great. Thank you, Connie. Another note in the chat. Try to have them start asking questions about the person and work, overall patient life, so it can provide context for their evaluation needs and coming up with a recommendation. Yeah, exactly. All those things that we talked about in the SOAP note informing the assessment. Awesome.
Can you all see my slide? Okay. Okay. So from here, I'm going to talk about a few other classes, one of which is transition to practice. So I do all of the placements every year of where they're going to go. But part of that placement process is to also prepare them for clinical education, which is a little bit more, I guess, complex than you might think it would be. So this class is just a couple weeks long, but we really pack it full of a lot of different material. And it's all of those things I feel like that aren't really covered in like device specific courses, but that are really important to be successful in a clinical setting. So you can see some of the competencies we met cover ethics, professional issues, exemplifying the role of the O&P, lifelong learning, community service, so on and so forth. So we have required readings as well. They have to read the NCOPE Residency Handbook, of course, the BCM Clinical Manual and our handbook. And then everyone goes through the ABC Code of Conduct, Professionalism, and Ethics. And then towards the end of the course, they also are going to be assessed on their knowledge of these items. So some of the areas that came about in the survey was professionalism, communication, conflict management, and time management. So for professionalism, we have, of course, a whole lecture about expectations, dress code, communication. But in addition to that, I'd like to bring in guest lectures every year, typically several. So we'll do a whole panel with several preceptors, and they'll give kind of their spiel about expectations, how to handle like residency burnout or balance. I have an example of a slide from one of our presenters last year. And then I also go through cases of past residents who may have demonstrated unprofessional behavior and what the repercussions would be of each. So that's kind of our take on professionalism. So they end up getting all together, I would say like 2 lectures and then 2 guest lectures essentially on this topic, which I think is quite a bit. We really beat it into them. From there, for communication and conflict management, we'll have the ombuds officer come over, and she does a little bit of a talk about communication strategies. But the most, I think, valuable part of this one is we really do role-playing exercises. So she gives the students scenarios that they're going to come across regularly while they're in residency. So this could be scheduling, this could be like competency concerns, maybe they think they should be doing more casting or whatever, and how to address those concerns with their preceptor. So how to set the meeting, open the discussion, and kind of clarifying what's at stake, but coming from a place of curiosity, not from a place of accusation, right? So they're going to work through these and kind of do them back and forth. And then we talk about like what they felt was the most appropriate way to address these. So another thing that came about from you guys' survey was time management. And this one I think is actually a little bit tricky. We do try to address this with the students. We have an assignment where they have to fill out how long each task they think will take. So for example, writing a note, casting a patient, modifying an AFO, ordering all the parts for a prosthesis. And then they have to tally up their time estimates and see if it matches to like an 8-hour workday, for example. And this just kind of starts the conversation on like, is there enough time in an 8-hour workday to get these things done? What is your schedule really going to look like? And how can you really refine to have a better workflow? So I'm sure everyone here who's had a resident knows they're very slow with writing notes in particular at the beginning, and then they get better and better over time. But we do start those conversations ahead of time, how they can make templates and cheat sheets and that kind of thing, just to like start to get them to wrap their mind around it and improve. And Ashley already kind of brought these up, but we talk about, different tips for success and what are the best ways to get along with the preceptor and to really, I guess she's could say, to really ingrain themselves into like the team environment in the clinic. They don't have a lot of time to really get through, or I guess you could say to build like trust. We try to do it as quickly as possible. So we talk about ways to do that and improve that. So I had a quick thing on if anyone has any questions on transition to practice. I feel like that was also a really broad sweeping overview, and then we'll talk a little bit about health behavioral counseling topics. Yeah. All right, there's no questions. I'll just move forward a little bit more. So this kind of carries on our questions about like communication and conflict management, but this time it's in relation to patient management as opposed to working within a clinical team setting. So these are some of the competencies. These are actually from health behavioral counseling too. I realized I probably should have put them from one. But it really covers behavioral science, communication skills, ethics, professional responsibilities. But for those who aren't super familiar with health behavioral counseling, it's actually defined as effective clinical communication skills that assist a patient with making a health behavioral change or decision, especially when a patient feels ambivalence toward a change or decision. So for all of us who have been in practice, that's about half of our patient population, right? So if you had a patient with scoliosis, but they're not comfortable wearing their device full time, or the parents don't feel comfortable putting the helmet on full time, navigating those conversations is a really difficult part of clinical care. And how to manage those conversations is introduced in the first semester in Health Behavioral Counseling 1. This class is taught by Dr. Garland. She's a psychologist and a licensed therapist who works in a children's hospital right now. So in this class, they're going to dive deeper into particular methods, one of which is called motivational interviewing. And motivational interviewing, again, is when you have someone who's in ambivalence toward a change. They know that this treatment is recommended by somebody outside of themselves. However, they haven't fully embraced that they need the treatment, and they're not, being fully compliant with the recommendations. So motivational interviewing is giving them the skills, it's giving the students the skills that they would need to navigate those scenarios, essentially. Another tool that they're given in this class is called shared decision making, which I'm sure everyone here has heard of that one. But this is also really embedded into those conversations for patients who maybe they don't fully understand how to wear the device, maybe they're not wearing the right amount of socks, maybe they're not coming in for follow-ups when they really should be, they're just taking the device off. So how to implement shared decision making in that evaluation in order to improve and really prevent those problems from happening in the first place. So, and if some of you guys were curious about OARS, OARS is one of the most common methods they use in motivational interviewing. And again, this is how to have those conversations with the patient, so where you don't get defensive. So when a patient is saying, well, I don't want to wear it for this reason and this reason, younger clinicians or newer clinicians may be tempted to be very defensive and just give them more education. But studies have shown that just giving a patient more education is not actually helpful. It just makes them more defensive. So with the OARS verbal skills, it teaches them to ask open-ended questions and to provide affirmations and reflecting back to them, letting the patient know that they're hearing what they're saying, and then summarizing to make sure that they fully understand for everything from the patient's point of view, as opposed to trying to just dump more education on them. And she goes a little bit more into depth on the next steps after this. But what's interesting in this class is a problem that happens is they're kind of lacking clinical context to really understand the relevance. So at this point in time, they've shadowed in a few clinics, but this is still the first year in the program, right? So some students just feel, why wouldn't a patient wear the device full time? They honestly, they don't believe us when they say that you're going to have this as a struggle. They think that everything is going to be great all the time. The other issue they come across in this class is that they're taking it with other medical students and physician assistant students, genetic counseling, things like that. So some of the examples are not relevant to O&P specifically. Because of that, we sometimes struggle a little bit with them like really feeling that this content is relevant to them. However, once they go out into residency, it only takes one rotation. So just 4 months out in the clinic setting, and they come out realizing like, okay, this is definitely relevant. It's going to come about quite a bit. So we introduced this class about 3 years ago. So this is Health Behavioral Counseling 2, and I teach this in conjunction with Dr. Garland. So we teach it together. And the students have to bring in all their own cases directly from the clinic. So things that they have seen or that their preceptors have seen. And then on the right-hand side here, you can see examples of the different topics that are going to come about. So the first one we really talk about is poor adherence, since that's the most common one we come across. But then we go into a little bit, I should say slightly less common, but just as important and even more difficult conversations. So if you have a patient who you suspect might have depression, we talk about identifying and addressing that depression, what the next appropriate steps are. If your patient might have PTSD or PTSS, how to identify that, what's the signs and symptoms, and what's the appropriate way to respond. And if you suspect possible abuse or neglect, where do you go to report those? What are the standards in the state that they're working in? And from each of these, the students has to either put together a whole case of something that they've seen and how they can use motivational interviewing techniques to address it, or they will put together, for the example of depression, they would put together a flyer and how they would present that information to somebody and what's a neutral way to present it to encourage a patient to seek the resources that they might need. So this is an example of one of the flyers for those depression cases. But what we found in this class is we actually get really good reviews. Once they've had those 4 months in clinic and they've had kind of those difficult conversations they're not sure to navigate, by the end of the class, they seem to feel much more confident and much more comfortable with these kind of more difficult scenarios. Brief today. All right. Any questions, concerns, thoughts?
So I'll share a topic, Lisa, that was shared via direct message. It's specific to the integrated residency model and our rotation length in particular, which was follow-up care. And this is something that we've heard about from a number of individuals. And the idea that when we're a new learner, I mean, anyone, right? All of us learn from mistakes, and having that access to kind of see what the outcome is from your interventional choice, what that might look like. One of the ways we've tried to address it, but I'd love to hear from you all, is encouraging residents to learn what they can from seeing those follow-up encounters from another clinician's decision, right? Like kind of deducing what happened in the interventional process that resulted in the requirement for, 5 different adjustments, for example, and trying to learn from that, even though they might not have been the one making the initial decision. But I know we've got a number of former residents in the room as well, who might want to share some thoughts. Mm-hmm.
Well, and we also had a comment in the chat from Michelle that she found it difficult to write the notes because each preceptor wanted them done differently, which is a good point. We don't actually put together a template for notes. We actually just discuss working with the preceptor to create a template at the beginning, and then they can utilize that once they're in the clinic setting. But yeah, I agree. Everyone likes to do it a little bit differently. So sitting down and learning right up front at the beginning what they're wanting and expecting makes it much faster and smoother transition. Yeah.
Okay, I'm going to throw a question out to the group, and I will sit here and wait for someone to unmute or ask a specific person to respond. But I think for practice management and professionalism, I think this is a really great topic area for answering the question, man, I wish I'd learned that in school. And so I would love to hear from you guys, out in practice now, and would just love to hear what were those, I wish we'd learned this in school moments. Did it relate to kind of business management? Did it relate to coding? Um, how to interact with colleagues and referral sources, anything like that? Because I know you guys didn't learn everything you know in school, so there's got to be something.
Hey, this is Brent.
Hey, Brent.
A lot of our current practitioners and new practitioners, we all have a little struggle deciding on follow-up visits, whether it's 3 months or 3 years after the delivery of a prosthesis in particular, when we should try to bill for an adjustment or repair, how to bill for an adjustment and repair, and when it's even financially advantageous to try to bill for an adjustment or repair. I feel like our industry being pressed to do more documentation and outcome studies, and we need to start charging for some of our time when we can. And I feel like all companies, including our own, does a poor job of attempting to bill for adjustments and repairs to both prosthesis and orthosis. So example, like 6 months later, a patient just has a simple adjustment of maybe needing a height change and a change of a pylon. We usually don't charge for that, but I think there's a possibility that you could, or adding a padding in the socket to make it fit tighter. If the patient, doesn't want to use more socks or doesn't want to have a new socket made, there's a lot of stuff that can be done to an existing prosthesis. So that's something I wish we knew more about, and the residents knew more about.
Yeah, Brent, I think that's a really great point. And I know that the residents kind of bring up some of those questions and share what they've seen practices do, but my understanding is that it varies greatly across practices. And it also depends on area of the country and, third-party payer and what you're able to do. Yeah, that's a good point. Anything else? There's a note in the chat. I think personally learning how to market or discuss with providers and explain what's new in terms of bracer prosthetic designs and how to approach a physician with this information. Yeah, that's a great point. I saw that actually come up in our alumni messaging board a little while back, kind of tips or tricks on what to do, best practices for in-services or marketing, things like that.
I'll add to Connie's comment that, when I was a resident, in terms of the marketing and in-services and stuff, my mentors at the time would give me the opportunity, like if they were invited to do an in-service, we were as residents given the opportunity to give the presentation, but the mentor went with us to the presentation so that, we can, it obviously makes you feel better that they're there and they can answer some of the harder questions that do require experience. But I always appreciated that opportunity, because after like 2 of them, you're kind of feeling like, I think I can go by myself. And I also am getting better at anticipating the questions that the potential referrals would ask. So I agree with Connie. I think that that's a really important skill. And I think one way to do that is to like model the behavior, right, for the resident, because they're going to be super intimidated, right? And there's like a lot to think about when preparing for that. And they really don't want to screw it up. And then sort of like along those lines, I just wanted to point out, and then maybe get Lisa and Ashley's commentary, anyone's commentary on it as well, that like, I think, and for those of you that don't know, I'm also on faculty with the program. And something that I try to consider when I'm even just teaching the students and talking to them about entering the workforce is that there's fewer and fewer students every year that have had any job before. And so, we really work hard to get them from like never having had a supervisor, never having to clock in, how do I manage conflict if I need to talk to my manager about something? And so there's a lot to take like modern students, because a lot of them can't get into programs without all of the extracurriculars that they have to do. So sometimes they don't have time for a job and that kind of thing. But I just wanted to throw that out there that it's difficult to, however you feel about not working and going to school and all that kind of stuff. They do have like a lot to learn, especially for their first job being such an important professional career.
Yeah, agreed, Sally. Thank you for sharing that context. I was going to add on the marketing conversation as well. I think we have seen for a very long time, and I personally experienced this as a resident as well. There used to there well, it's still there, but it will kind of transition in the new residency standards. A portion of competency that was related to communication with referring providers, and often the residents are shielded or limited from that, especially in cases where the preceptor, the clinician, is wanting to do everything they can to maintain their relationship with the referring provider. And so it's like, no, resident, I don't want you messing this up. And totally understand that, but sometimes that means the resident doesn't get any practice in developing that skill set. So Sally, similar to what you were saying, right? That's a great opportunity to say, hey, I want you to come and sit down and listen to this conversation I'm about to have with a referring provider, and let's talk about it when I'm finished, and we can debrief. Yeah. All right. Well, we really thank you guys for your time and conversation. And if you think of anything related to this topic where you want to share a little bit more with us about, the things you wish you learned, or where you see a gap from academia to clinical practice, don't hesitate to reach out. And we thank you guys for taking the time to be with us today. If you need it, take a look for the recording in the folder, given the reminder email, and the link for the evaluation and quizzes there as well. We hope you guys have a great afternoon.
Thank you.
Thank you.